was awesome. We got out. Yeah. It wasn't as many like cities. It was like it was just one room. Very good. This one had one room, but it was like yeah. I didn't think it was. We got out like 10 minutes ago. I didn't think we were out. We did. It was intense. It wasn't like that one we did in Travelology was legit. Like they set an atmosphere that was actually scary. This one was like intense. They didn't like. There was no like limit to the amount of hits you could get. So yeah, so it was like because there was a ball thing that after like 3 false numbers locked to 5 minutes, and we only had hey,
Well, welcome. We're right on time. Before we get going, I just want to introduce our newest member, Barbara Clay. Barbara, would you be willing to just give us a 2-minute to everyone introduction about? You don't have to give us your whole life, but exciting. Yeah, if the green light shows, then it's working. If not, we'll give you another.
I was concerned you were going to ask me to do a quiz song in advance. Hi, everybody. My name is Barbara Blakeney, and I'm here in the innovation position with the commission. My background in innovation is that I was a CMS innovation advisor for CMS a few years ago, and my last job prior to retiring was as the innovation specialist for patient care services at Mass General Hospital, and I am thrilled to be here and be part of this work. I have a lot of questions for a long time as I get up to speed, but I'm very excited about the work that the commission does, and very excited about being able to join the commission and bring my expertise in innovation as well as my background as a nurse to this group. So thank you all for
Well, welcome, Barbara. We go way back, and it's great to have you. Thank you so much. So let us start by we have the minutes of December 13th before you. Is there a motion to approve? I should point out that there are a number of commissioners who, for one reason or another, are flying around the world or doing whatever. So a little short-handed, but as far as I know, Colleen, we still have a quorum.
Yes, quorum is in.
I should have asked you that first. Where's the boy? Where's okay, so there's a motion on the floor. Are there any additions, corrections? If not, is there a motion to approve? Okay, all in favor? Aye. Okay, great. Okay, sounds reasonable. Okay, so David, I know a lot's been going on. Can you just bring us up to date?
Great. Well, good morning or good afternoon, everyone, commissioners, and from the staff, Barbara. So, a warm welcome to the board and to the commission. We're extremely excited to work with you and to have your perspective and expertise inform the work of the commission moving forward. And so, congratulations on your appointment by the state auditor, and welcome. So for today, this is our first meeting of 2019. And we have a few main agenda items, but a focused meeting today. I will first give an executive director's report with some updates on some of our programs and some of our most recent activities, some upcoming publications. But the bulk of today's meeting is going to be focused on two main agenda items. One is going to be a presentation by the staff here on some initial findings of the impact of the partners' acquisition of Care New England, a multi-hospital system located in Rhode Island. And then we're going to shift gears and return to our Cost Trends report, which was the bulk of our presentation at the December meeting. And here today we'll focus more on the policy recommendations included in that report and have a vote to consider the issuance of said report by the HPC board. First, though, I did want to spend some time in my executive director's report here at the beginning of the meeting, highlighting some of the work that's we've been up to. First, if you want to move to slide 7 here, we were very pleased just a few weeks ago, on January 24th, to work with the Massachusetts Coalition for Senior Illness Care on a webinar about what accountable care organizations are doing around serious illness care. We did this in partnership with the coalition to really highlight some of the emerging practices that ACOs are bringing to bear in this really important policy field. Through our ACO certification program, this was a question that we asked all of the 17 certified ACOs around what activities they are doing in this particular area. And so we wanted to highlight some of the best practices specifically from Baycare, Leahy, and partners. And so had a really, I think, wonderful webinar with over 120 participants really highlighting some of the best practices. I won't read through the quotes that are here, but nonetheless it was a very engaged audience. And when you do a webinar, you're never quite sure how many people are going to join, but we're really pleased with the attendance and the participation in the conversation. So a good example of how we're thinking about leveraging the information that we collect through the ACO certification program and partnering with others to have that inform really good policy conversations. So the next 3 slides are really around our 3 main investment grant programs that we run at the HPC. So wanted to just touch base with you about where we are in terms of the life cycle of our 3 main grant programs. So on the first slide here, on slide 8, this is our community hospital chart phase 2 program. And as you can see by the kind of we are here marker, we have closed out the programs. All of the phase 2 programs have now ended. The programs, our implementation period for those programs have ended, and the final payments have been made to all of the hospitals. We did have an extended period of some no-cost extensions where the hospitals were continuing their programs and continuing to draw down funds from the HPC. So we are definitely in the closeout period of this program and really focused on evaluation and summative materials about what was the impact of this program, what did we learn from this program, and can expect that we're going to have a series of publications and conversations throughout this year reflecting on the impact of the CHART program in particular. So we still are working, as you might imagine, the evaluation is continuing, and we're still have some final data that we're going to analyze. But we are definitely in the final phases of evaluation and learning dissemination for the CHART program. The next big investment program that we are running is the Healthcare Innovation Investment Program. The implementation periods for these grants was anywhere from 12 to 24 months. And as you can see by the We Are Here marker, we are reaching the end of the implementation period, the main implementation period for many of these grants, although many of them have requested and we are continuing to offer no-cost extensions. So to the extent that they haven't spent down the entire amount of the grant, we'll continue to allow them to continue to implement their programs. But we are kind of closing out, beginning to close out some of these grants as well. Again, the focus is on final closeout, final payments, and again, really around evaluation and what did we learn, what were the impacts from these programs. So again, it's going to be a main focus for this year in terms of sharing information around the HCII programs. And then finally, our Shift Care program, which was focused on initiatives that would address social determinants of health or behavioral health integration, or our focus on the initiation of medication-assisted treatment in the emergency department for patients who present with opioid use disorder. Very different point in the life cycle for these grants. We have finished contracting with all of our awardees, and they are all in the initial preparation period, and we'll begin the implementation period probably around April and May, when they're actually going to start seeing patients through these programs. So we do have some time in the beginning where they're kind of gearing up, hiring staff, and beginning the program before they'll start to see patients. So very early on in this phase, and again, these are 18-month implementation processes. So just wanted to give you a snapshot of where we are with the three different main investment programs, and we'll have a lot more to say as we get some of the results back and evaluation results in the future. Any questions on the investment programs, Tim?
Yeah, just what's the number of grants that were given in the Shift Care? I forget just the number.
15.
Particularly on the chart and the HCII, can we get a sense of how many institutions were able to sustain the effort even without the funding at some level?
Yeah, so we do anticipate that's going to be a big part of our kind of summative report is what we know about what hospitals continue to implement those programs. Some of the hospitals did continue them with support from Mass Health and the Mass Health ACO program. Some of the hospitals we know did continue them and are supporting them with some philanthropy dollars. And some of the hospitals are continuing the programs just out of their kind of operating budgets. I will say at a high level, a majority of the hospitals did continue with these programs even beyond the grant period. And I think we'll have more specifics about exactly who and how they're continuing these programs. But that would be part of the evaluation report. So it is an important point. Even though the grant implementation period for these are ending, our anticipation is that a lot of the activities obviously continue beyond when the grant ends. So the next piece of my executive director report that I just wanted to touch on is an update on our Office of Patient Protection. From time to time, we have the opportunity to share some new data around the Office of Patient Protection, and we'll just give a brief reminder of the office and its role. This office was established in Massachusetts in the 90s and was run out of the Department of Public Health until 2012 when it was transferred to the Health Policy Commission as the Health Policy Commission was established. The office regulates fully insured health plans, commercial health plans in Massachusetts, specifically with regard to patient appeals around medical necessity claims. So we both regulate the process by which patients can appeal internally, what we call an internal appeal, where they appeal directly to their health plan and have an opportunity to have an additional review of their case. And so we collect information about the process by which patients are able to appeal to their health plan. And then there's a secondary process where if the health plan still denies that it is medically unnecessary and denies that claim, patients do have the opportunity to come to the Health Policy Commission and come to this office and seek an external review, which is a final third-party binding review. And we administer that review process. We do not conduct the reviews ourselves. We do not have clinical expertise on staff that does that. We contract with organizations that do these types of external reviews where they have the right types of clinical expertise. They review the case file, they review medical information, and ultimately will make a determination about whether that service is medically necessary. In addition, the Office of Patient Protection also approves open enrollment waivers. So these are patients who are seeking to be able to get health insurance coverage outside of the normal open enrollment process or period. And there are certain circumstances where that is allowable under state law, but patients do need to apply to us, and we'll adjudicate whether there's a waiver that would allow them to purchase insurance outside of the normal open enrollment period process. And then on the third bullet here is a brand new, first in the country appeals right, where patients who are risk patients of ACOs or risk-bearing provider organizations can actually appeal decisions that are made by those ACOs in terms of referrals or the type of care that an ACO, an actual provider, may be making a decision about whether that care is appropriate for patients. And here too, there is both an internal opportunity for patients to appeal to their ACOs, and now we have just established an external appeals process where patients can come to us and again have a third-party determination about whether that care is appropriate.
David, I never asked you or Lois. So if a patient is in a federal ACO risk-bearing program, can they come to us?
So these are commercial risk patients. So Medicaid patients have their own processes for appeals of this nature.
I'm talking about Medicare.
That's right. So this does not apply to Medicare.
So it's just commercial.
Yep.
How are people made aware of the appeals process?
So in the case of kind of the insurer appeals process, there is notice that is requirements that when there is a denial sent to the patient, that there is information prominently displayed on that denial around their right to an appeal and contact information with the Office of Patient Protection. Lois, maybe talk about the ACO appeals notification process.
The same thing on that side, as you recall, when we promulgated our regulations, we had provisions around providing notice to patients and making sure that ACOs can choose to do individual contact by mail to each of their attributed members, but at a minimum, the ACOs need to post at regular sites of service or regular sites of care in doctors' offices and the like, providing information about how patients can appeal. I think this is, as David said, we are just beginning. We've implemented this program. We have not actually processed any requests for an external review, but as you may recall, we have collected information about internal reviews as part of our sort of pilot run-up to developing those regulations, and we've had, over the period of time, increasing numbers of internal reviews, so I think the word is getting out. And Nancy Ryan is our Director of Office of Patient Protection, and we are in the process of planning some outreach and implementation just with the provider organizations themselves, and in addition to health plans, because of, as we talked about in the development of regulations, some potential for confusion or overlap, but there's certainly a role for health plans also to provide that information to consumers.
So wanted to share just a few data points with you on what we learned in our most recent annual report. So first, just want to highlight that we did issue data points on some of the key data findings from our most recent annual report, which is posted on our website of the Office of Patient Protection. And just as a reminder, and Colleen will talk a little bit about this, but data points is our online series of briefs where we will examine a specific issue and have interactive data capabilities through a Tableau feature, so people can go on and be able to toggle and use the data in their own way to look at some of the data trends that we have. So it's one of our new tools in communication and getting some of this data out for people to examine and look at. So one of the interesting trends that we looked at over time and is displayed on this graph is that we are seeing that there is an increasing number of internal appeals. So again, these are patients who are appealing to their health plan that were denied services. And as you can see on the line graph, over time from 2014 to 2017, we are seeing an increasing number of patients availing themselves of that right. But interestingly, when we look specifically at internal appeals for behavioral healthcare services and behavioral healthcare treatment, we see that that is actually declining. And so those are the bar graphs on the bottom, both in terms of a total number, but also as a proportion of the total number of appeals. So you can see, and it is hard to see obviously on the display here, but in 2014, about 26% of all of the internal appeals were for behavioral health treatment. And in the most recent year, even though the number has gone up of total appeals, the proportion is down to 12%. It's hard to draw kind of very firm conclusions from this data about what we may think here, but I do think we understand that health plans have removed some barriers to behavioral healthcare treatment and have made behavioral healthcare treatment during this period more accessible. There have been mandates that have gone into place during this time period around coverage for behavioral healthcare services. And so it does appear, at least from this data, that there are fewer patients who are for behavioral healthcare treatment who are needing to go through an internal appeals process. We're going to continue to track this data, and maybe a place for us to talk a little bit more with the health plans about what they think is going on here in terms of their internal appeals processes. So when we look at the adjudication of those internal appeals, so in 2017 there were a little over 14,000 kind of member grievances, of which about 6,000 were specifically around a denial based on medical necessity. And you can see the resolution of those. And again, these are the internal appeals, so we do get this information from the health plans. And you can see that over a majority of the patients who did appeal were found that those decisions were overturned. And so the approved here is that these were resolved in favor of the patient, in favor of the consumer. So more than 50% of patients who did go through this internal appeal process ultimately were able to be approved for coverage for those services. And then the next slide looks at this specifically for then those patients who were denied, and then came to the Health Policy Commission for an external review, is a very much smaller number. So in 2017, we only received 215 eligible requests for an external review. And so that these are the ones that we process internally, and we did here too see about half of those appeals being resolved in favor of the consumer. I think generally what this tells us is that patients should avail themselves of these rights, that there is an opportunity for coverage, and even beyond, even if they're denied by their health plan, that availing themselves of the external review process may result in coverage for these services even after the health plan has denied it multiple times. And so we are continuously always trying to get the word out about these rights and making patients and consumers and residents of Massachusetts aware of these rights through these processes. One more final kind of breakdown here. This is just the external reviews, and we broke this down from medical, surgical, and to behavioral health care. And you can see here on the right-hand side of the reviews that were done for behavioral health care treatment, there too, almost 60% were resolved in favor of the consumer. So again, even of those patients who were denied services, if they come through our process, there is an ability to continue to have that decision overturned and to get coverage. The next slide here is really just kind of keeping track of our open enrollment waivers. We run this program in very close communication with MassHealth and with the connector, especially as the connector is the main administrator of the open enrollment period process. We've had a pretty steady stream of these over the years, around 300 to 500 a year. So not an insignificant number that we kind of have to continue to process along the way. And then finally, I think one other piece about the Office of Patient Protection is that we have staff who answer the phone, and we have a pretty prominently displayed hotline, and certainly with a name like the Office of Patient Protection, there are many consumers who are come to our office or call our office seeking help navigating the healthcare system. And even though we may not be able to, through our, it may not be an appeals process that is right for our office to adjudicate or to help administer, we always try to navigate and help people figure out where is the right place for them to go to be able to understand and be able to get the services they need. So we often will have Mass Health members who will call our office looking for help in terms of appealing a decision, and we'll be able to connect them with the appropriate people at Mass Health. So we have a lot of consumer inquiries that come in through the hotline, over 1,300 a year. So multiple phone calls a day that we're helping people and helping residents navigate the healthcare system. So wanted to just have that opportunity to again make a commercial and for the office and for the great work that the office and the staff there do. So thank you. And all of this information is up on our website. With that, for a few more updates, I'm actually going to turn it over to the Deputy Executive Director, Colleen Nelson-Meyer, to talk about some other things that are new on our website.
Great, thanks, David. So as David said, HPC Data Points is a series of online briefs that we launched in April of 2017, featuring interactive graphics on relevant health policy topics. We release new issues every couple of months. Just to review a couple of topics, data points that were released in the past, we did the rise of urgent care centers and retail clinics. We did a data points on spending variation for imaging services. We did a data points on the growing opioid epidemic and data points on the avoidable emergency department use in Massachusetts. So you'll see on this slide, we're excited to announce the 10th data points issue, which is available on our homepage now. The newest edition is a little different. Rather than a deep dive on a particular health policy topic, it describes the HPC and SHIA's annual process for monitoring healthcare spending growth against the benchmark, and the HPC's authority to modify the benchmark over the next several years. So the brief uses interactive graphics to walk you through this annual process. So reviews, starting with the healthcare cost trends hearing in the fall, CHIA's referral of high-cost entities to the HPC from whom we may require a performance improvement plan, the annual cost trends report, which will be released today, and finally the benchmark setting process, which is coming up in March. Which takes me to the benchmark hearing. So in 2019, the hearing on the potential modification of the benchmark for calendar year 2020, we're going to hold the hearing this year at the State House in Gardner Auditorium on March 13th at 12 p.m. The benchmark this year is set at the default rate at 3.1%. That's for the years 2018 to 2020. We co-host the hearing each year in conjunction with the legislature's Joint Committee on Healthcare Financing, and as per years past, we expect many members of the legislature to attend. So also finally, we just encourage market participants and stakeholders to attend the hearing, offer us feedback on cost trends, drivers of spending, and whether or not modification to the benchmark is appropriate this year. Any questions on the hearing? Great. All right, I'm going to turn it back over to David for some exciting updates on benchmarks and other stages.
Yeah, so continuing on the theme of healthcare cost growth benchmarks, I'm really pleased to give an update around some of the national activity that's occurred in the last couple of months around other states being inspired by the Massachusetts model and our approach, our market-oriented approach to controlling healthcare cost growth. And so I want to highlight activity in 3 states since the last time we met. The first is Delaware, and so late last year, Governor Carney issued an executive order establishing a healthcare cost growth spending target, and this was a result of very significant stakeholder processing, probably a year and a half of work in Delaware, where they examined what a lot of other states were doing, including Maryland and Vermont, Minnesota, and Oregon, and ultimately had a really big community conversation about controlling healthcare costs in Delaware. Delaware is one of the more expensive per capita healthcare states in the country, and they really were able to coalesce around this idea of a target for controlling healthcare cost growth inspired by Massachusetts. I think, interestingly, they also included some quality improvement targets and benchmarks as well. So they combined and married both a spending target with some very specific targets around reducing emergency department use, reducing opioid overdose deaths, reducing tobacco use, reducing obesity rates, increasing physical activity for high school students, controlling diabetes. So they have a whole set of kind of quality improvement targets as well as a spending target. Their spending target for the first year is going to be 3.8%, but that will tick down over time, and I think get as low as 3% target growth by the year 2022. The second state to highlight here is Rhode Island, which literally just last week, their governor also signed an executive order establishing a target for total healthcare spending growth, and had set that target at 3.2% through 2022. And again, I think the Rhode Island process was an extensive one with stakeholders, and was supported by Brown University, and they also looked at another of other state models, and I think came away feeling really inspired by the results that we've been able to have here in Massachusetts and enabled in terms of controlling healthcare cost growth, and so had made that part of their portfolio of levers to control healthcare cost growth. And then finally, Oregon also had a legislative task force that was actually specifically mandated to look at Maryland and to look at the feasibility of importing the Maryland model to Oregon. The task force did not recommend the Maryland model for Oregon, but in the course of their activities did look at a number of other states, including Massachusetts, and that task force unanimously recommended that Oregon move forward with a Massachusetts-style total healthcare spending growth target. They have not had an executive order or legislation, but they are planning and in the beginning processes of implementing this. I would just highlight, this is obviously very great work to see that the work here of the Commission and of the Commonwealth and the market participants here is being picked up by many other states. And I think that one of the core principles of our approach here is this idea of total healthcare spending controlling and thinking about all of the different pieces of healthcare together, not just Medicare, not just Medicaid, not just the commercial side, but this concept of an all-in target that can really mobilize activity at a state level to say, how can we begin to control these healthcare costs? I would say all of these other states are also beginning to implement the data assets that they need to do this well, and that will be ongoing work for a while, where we have just tremendous data assets to be able to do this work. I would also finally say, I think in each of these cases, the states did consult with staff at the Health Policy Commission and commissioners of the Health Policy Commission. So thank you for those of you who spent your time doing that. And Professor Cutler, I know that you advised on some of these states as well. I don't know if you have anything further to add.
I'll echo your points, two of them in particular. One is they find the model very attractive because it's not just thinking about their own Medicaid programs, which they have a strong belief that when they cut their Medicaid programs, that results in private premiums being higher, private spending being higher. Nobody wants to do that. So they're very eager to think about all-inclusive solutions. The biggest challenge for the states that I know about, I was an advisor to Delaware, and I've spoken over the years with people in Rhode Island about it, is the data issue. That is, they don't even know where they're starting from and stuff. And so we are really blessed because we had at the time, and as a state have continued to invest in the data resources that allow us to monitor things. And to the extent there's anything that's a hard lift in these states, it's getting the data assets in place. And as part of this, they had to make a commitment to go ahead and do that. And I think they spoke with you and certainly with Chia about, we got as many questions about how do you duplicate a Chia as we did about, what exactly do you do in this particular situation and stuff. So I think it's remarkable foresight on the Commonwealth's part to have invested in those assets for quite a long time.
Any other questions? And think we will keep, I plan to keep this commission updated as we see other states continue to innovate and adopt different ways of approaching healthcare cost containment. So final slide here, some upcoming publications.
Sure, so in addition to the cost trends report, we just wanted to provide an update on a number of publications that we have in the works for 2019. So a number of studies and research projects in the prescription drug space. One includes an issue of data points on generic drug pricing markups by pharmacy benefit managers, or PBMs. This was planning to be published in the next month. We are also publishing a study on the practice of shifting drug distribution channels, also known as white bagging and brown bagging. That was a legislative direction, which will be slated for release very shortly. And finally, in the pharma space, we're conducting a study on the practice of discount vouchers for prescription drugs, and that's slated to be released early this summer. For our investment programs, we have a number of profiles on our awardees that we're publishing. These will offer snapshots on our various awardees' care models and achievements to date. And then on the way this spring, we have a third policy brief coming out of our ACO certification program. This is focused on the risk contract experience and performance management approaches of our HPC certified ACOs. Finally, last but not least, we are releasing new findings on the barriers with individuals with co-occurring disorders. These are patients with mental illness and substance use disorders, and these will have accompanying policy recommendations to address the issue as well. So all of these publications will be announced at upcoming public meetings and will be available on our website and our listserv, so please stay tuned and be sure to keep the board updated.
Questions of either Colleen or David on this one? This is incredible. I want to play around with this.
Okay, tab left. Great.
All right, great. Well, thank you. Thank you for the opportunity to give some updates here. And as you can see, there is a lot of work going on here at the HPC. So now to turn to our two main agenda items for today. So the first I will tee up here is a conversation around one of our material change notices. So this slide is our standard slide that just updates the types of transactions noticed since we began. I won't speak much to this. But we do currently have one notice that is under review. So this is still within our initial 30-day or so of review process where we receive a notice about a material change, we analyze the potential impact of this transaction, and ultimately have to make a determination about whether we think it is likely to have a significant impact, in which case we would recommend moving forward with a full cost and market impact review, or otherwise we would close the initial review and the transaction may move forward. So this notice that we're going to talk about for the next 20 minutes or so is still under review in this initial review process, although our timeline by which we need to make a final determination about whether or not to move to a cost and market impact review is approaching. So we wanted to have the opportunity here today to be able to present some of the findings that we have about this transaction, get your feedback and questions on this to help inform the final decision about whether or not to move forward with a cost and market impact review. That is not a decision we need to make here today, but did want to have the opportunity to present and to get your questions and feedback on it. Because this is a unique transaction for us in our 6 years of reviewing these transactions. So the acquisition that we're going to be speaking about today is the acquisition of Care New England, which I said is a multi-hospital system based in Rhode Island by Partners Healthcare. Partners Healthcare has acquired other hospitals that have been out of state that we have reviewed in the past, including in New Hampshire and in Connecticut. However, this is a more significant transaction in terms of the size and importance of Care New England to the Rhode Island market. And so we're going to spend a little bit more time than we usually do in terms of sharing with you some of the analysis we did. And we did, I think, do a deeper dive here than normal transactions, reflecting the fact that Partners Healthcare is the dominant healthcare system in Massachusetts, and Care New England is a significant provider right across the border in Rhode Island. So with that as kind of a preview, I'm going to turn it over to Megan Wolf, who's our Deputy Director for Market Performance and who is leading this review, to talk about first what our authority is when we do these out-of-state reviews, and then to walk through some of the findings about what we know about this transaction.
Thank you, David. So as a quick refresher, the HPC has the authority to review transactions involving a merger with or acquisition of or by a hospital system, including an out-of-state hospital system. Last year, the HPC chose to limit its review of out-of-state transactions to acquisitions of hospital systems in New England or New York. For these acquisitions, including the transaction currently before us, Partners' proposed acquisition of Care New England and Rhode Island, our analysis is focused on the potential cost, quality, and access impacts in Massachusetts. In walking through our findings, I'll begin with a brief overview of the parties. As I think everyone is aware, Partners is the largest healthcare system in the state by a margin, both for its hospitals and physicians. It has 8 general acute care hospitals in Massachusetts, 1 ophthalmology and otolaryngology hospital, and 1 psychiatric hospital, as well as a payer, Always Health Partners, formerly Neighborhood Health Plan, and home health and rehabilitation providers. It also contracts on behalf of more than 6,700 physicians. Partners Hospital and physician prices are also among the highest in the state. To provide some quick context about healthcare in Rhode Island, so Rhode Island, as you know, is quite small. It has 12 hospitals. Its largest health system is Lifespan, which owns 4 hospitals in light blue on this map, if you can see them from there, including Rhode Island Hospital, the state's largest hospital and academic medical center. As you can see on the map, hopefully, Rhode Island Hospital and Lifespan's Miriam Hospital, as well as its psychiatric hospital Bradley, are in Providence, Rhode Island, which is about 10 minutes south of the Massachusetts border, while its 4th hospital, Newport Hospital, is in the southeast part of the state. Care New England is the 2nd largest system in Rhode Island, with 3 hospitals in dark blue, including Women and Infants and Butler in Providence, and Kent County Memorial Hospital in Warwick, which is about 30 minutes south of the Massachusetts border. There are a few other hospitals sprinkled throughout the state, but those are the 2 main systems. With regard to Rhode Island's commercial health insurance market, Blue Cross Blue Shield of Rhode Island is the largest payer, with about 60% of the market, followed by United, which has about 20%. Tufts Health Plan, Neighborhood Health Plan of Rhode Island, Cigna, and Aetna also sell insurance in Rhode Island with very small shares. So as we just saw, Care New England is Rhode Island's 2nd largest health system. Kent County Memorial Hospital in Warwick is a general acute care community hospital with the 2nd highest volume among Rhode Island's community hospitals. Women and Infants Hospital in Providence is a specialty hospital for women and newborns with a focus on labor and delivery. Butler Hospital in Providence is a psychiatric hospital. Care New England also had a 4th hospital, Memorial Hospital in Pawtucket, which is just north of Providence, which closed at the end of 2017. Care New England continues to provide outpatient services in Pawtucket. Care New England employs approximately 350 physicians, almost entirely specialists, in Care New England Medical Group. Care New England also participates in an ACO, the Integra Community Care Network, which includes a number of additional primary care physicians and specialists. Care New England has teaching affiliates with Brown University's Medical School and the New England College of Osteopathic Medicine in Maine. A 2012 study found that Care New England has among the highest prices in Rhode Island. Here you can see the primary service areas of Brigham and Women's Hospital in pink and the combined primary service areas of Care New England in blue. So, as you know, our definition of a primary service area is the area from which a hospital receives approximately 75% of its commercial inpatient volume. And as you can see on the map here, Brigham and Women's primary service area does not extend into Rhode Island, although it comes very close, while Women and Infants service area does extend into Massachusetts. That's the blue there.
So looking at the map, you can see that the vast majority of the parties' patients are not coming from the same regions. This provides some evidence that the parties may not be head-to-head competitors in their service areas. Parties have a clinical affiliation dating back about 10 years. The affiliation is focused on cardiovascular care provided by Brigham physicians at Kent, Women and Infants, and at physician offices in Pawtucket, and includes a full cardiovascular health program at Kent. The affiliation also includes a surgical program at Kent focused on vascular, thoracic, and colorectal surgery. Under the proposed acquisition, Partners subsidiary Brigham Health would become Care New England's corporate parent. The parties have identified several goals for the transaction, including stabilizing Care New England's finances, enhancing the scope and quality of Care New England's services, and strengthening Care New England's programs with Brown University's medical school. The parties have also stated that Care New England will continue to conduct its own payer contracting. The parties are considering establishing new ambulatory sites in Rhode Island that would not charge hospital facility fees. They have no plans to reduce current Care New England services, including behavioral health services. So as always, in a preliminary review, HPC staff reviewed information on potential market consolidation that could affect Massachusetts, as well as changes in referral patterns that could increase costs for Massachusetts. Here we focused on two potential referral pattern changes that could impact Massachusetts. One, the potential for shifts of Massachusetts patients to women and infants for maternity care, and the other, the potential for shifts of Massachusetts patients to Brigham and Women's for tertiary or quaternary care. We analyzed these questions using discharge data and all payer claims data from both Massachusetts and Rhode Island, examining current inpatient volume and flow patterns and comparing prices at the parties' hospitals and nearby competitors. So first, looking at changes in market shares and market concentration, we examined market shares and concentration in the parties' service areas, starting with maternity services, because maternity care is an important part of Care New England's service mix. As you can see on this slide, while both Partners and Care New England provide significant maternity care in their service areas, and so for Care New England you would be looking at the Women and Infants and Kent PSA columns, and the percentages there are the shares that each of those providers provide in that service area, so to patients living in those geographic regions. So while both Partners and Care New England provide significant maternity care in their service areas, their shares are very low in each other's service areas. Because Care New England is not competing with Partners in Partners' service areas, both Brigham and Women's and Newton Wellesley, we do not see a reduction in competition for these services there. Looking at Women and Infants' primary service area, which of course is less relevant to the Massachusetts market, we see that Care New England is very dominant, which drives the high concentration and increase in concentration in that area as measured by the HHI figures. Would it be helpful for me to review what HHI is? I think most of you have been through this before. Very quick, sure. So HHI is the Herfindahl-Hirschman Index. It's an initial screen used by antitrust agencies for the potential for anti-competitive impacts of a transaction. A transaction is presumptively anti-competitive if after the transaction the HHI is above 2,500 and if the change in HHI as a result of the transaction is above 200. So although we see an increase in concentration in Women and Infants service area here in the leftmost column of shares, Partners' share is relatively small at 2.9%. So Partners is unlikely to be acting as a competitor to Care New England for these services now. We also looked at the parties' shares of maternity services in parts of southern Massachusetts and northern Rhode Island from which the parties both receive patients, focused on the service areas of Charlton Memorial Hospital, which is part of South Coast, and Sturdy Memorial Hospital. The The parties are more significant competitors here, particularly in sturdy service area, which suggests that some competition would be reduced in this limited area after the transaction. However, the parties' combined shares of maternity services at 36 and 69% respectively are smaller than they are in Care New England service areas in the previous slide, where their combined shares were 85 and 93% respectively. We also looked at all other inpatient services to understand the broader market. So the chart here shows all inpatient services except for maternity. Similar to what we saw for maternity services, in partner service areas where Care New England is not providing any non-maternity services, we do not see a reduction in competition for these services. In women and infants primary service area, Care New England's shares of non-maternity services are much lower than its share of maternity services, and as a result we see a smaller effect on competition for these services. Stop for questions before moving on to care redirection. Hearing none. In analyzing the potential for shifts in referral patterns following the transaction, we again focused on Massachusetts impacts. First, we examined the potential for Massachusetts patients to shift from Massachusetts hospitals to women and infants for maternity care. The most likely shifts would be from patients of partners' primary care physicians, who would be newly incentivized to refer to women and infants where convenient for patients. We found that currently most partners' patients already use partners' hospitals for maternity care. Some of these patients, living close to women and infants, might choose to deliver at women and infants instead. It is also possible that other patients will shift to women and infants from other local hospitals due to increased partners' presence in the region, although as we've seen, women and infants already has a very strong reputation and market position. When we examined the parties' prices, we found that women and infants is always higher priced than Newton Wellesley, and sometimes higher priced than Brigham and Women's, depending on the payer. Based on current patient flow patterns, if all partners' patients living within 30 minutes of women and infants switched from Brigham and Women's or Newton Wellesley to women and infants, it could increase spending in Massachusetts by approximately $120,000 a year. Charlton and Sturdy are both substantially lower priced than women and infants, and shifts to women and infants would increase spending. For every 1% of each hospital's vaginal delivery volume shifted to women and infants, the spending impact would be about $30,000 a year. We also considered the potential for shifts in tertiary or quaternary services from Rhode Island Hospital, Rhode Island's primary tertiary care provider, to Brigham and Women's. After the transaction, Care New England physicians might seek to send more patients to Brigham and Women's where appropriate. However, the majority of Care New England's primary care patients are Rhode Island residents, so the Massachusetts impact of such shifts would likely be small. Other patients might also shift from Rhode Island Hospital to Brigham and Women's due to partners' increased presence in the region. Currently, approximately 300 Massachusetts commercial patients use Rhode Island Hospital for non-emergency care each year, and that's both tertiary care and less complex care. We compared the prices of Rhode Island Hospital and Brigham and Women's for 6 complex DRGs that are commonly provided by both hospitals in cardiovascular, orthopedic, and oncology service lines. We found that on average, Brigham and Women's is about 11% more expensive than Rhode Island Hospital for these procedures. If all of the Massachusetts patients who use Rhode Island Hospital for scheduled tertiary care switch to Brigham and Women's, spending could increase by $180,000. We also examined the potential for changes to quality and access as a result of the transaction. We found that there is some potential for improved quality as a result of the transaction, especially in Rhode Island, and the parties have plans to work closely to advance population health management programs in Rhode Island. On measures of patient experience, we found that partners hospitals generally perform well, and Care New England hospitals have somewhat mixed performance. On maternity process measures, Brigham and Women's performs well. Women and Infants performs not quite as strong, but did perform better than Brigham on one measure that we examined, C-sections rate. With regard to access, we did not review evidence that this transaction would have a negative impact on healthcare access for Massachusetts patients. As I mentioned previously, the parties do not have plans to reduce services, including for behavioral health. So I'll pause there for questions.
Any questions, comments? I think it's very helpful to show the depths that we looked into to make sure that you know how a pretty large system in a neighboring state affects Massachusetts. Thank you. Any questions?
Could you just review what the their own internal review process is?
Sure, to the extent that I'm aware. So the transaction is currently under review by the Rhode Island Department of Health and Attorney General's office, and they have a coordinated review process. The parties applied for and received an expedited review, which is a 90-day review once Rhode Island deems their notice application to be complete. Sometime during that 90-day review, some of the materials submitted to Rhode Island will become public, some of them will be deemed confidential. And I'm not explicitly aware where they are in their process, but I believe that we will be completing our review prior to theirs.
And are we in communication?
Yes.
Can you just remind us of the process, if any, for the HPC to monitor some of the commitments that they made in this submissions, so around facility fees, their commitment to not reduce any behavioral health services? It'd just be helpful to kind of remind what the process is for ensuring that those commitments are upheld.
Sure. So with all of these transactions, I think we always have the opportunity to do a post-transaction review. Here, those commitments are really focused on Rhode Island. And so the commitments were around where they're making expansions of ambulatory services in Rhode Island, that they would not implement facility fees, and a commitment that they made around not reducing healthcare services at Care New England in Rhode Island. So I think there's an open question to what extent the Commission deems it appropriate to kind of continue to track the activities across the border of that institution. I will say, I think we, as Megan did mention, the one area where we did see the potential for some reduced competition in Massachusetts was specifically in the region right over the border, where both Partners and Care New England are kind of more direct competitors. It's a small geographic area in Massachusetts, but it does include areas right around Sturgey Hospital and Charlton Hospital and South Coast. And I do think it may be appropriate for us to continue to track to see what, if any, impact the transaction may have on those specific institutions if care is if patients that would otherwise go to those institutions are now going to either Partners or to Women and Infants right across the border. That would be a place where I think we may want to continue to monitor and track.
So,
Just want to point out one other possible effect on Massachusetts, because I agree most of the effects are in Rhode Island. To the extent that what happens is people from Rhode Island with needs for very advanced hospitals come into, say, Brigham and Women's Hospital, and Brigham and Women's Hospital is already reasonably full. That might mean that other patients in Massachusetts who don't need such an acute hospital would then be more likely to go to a community hospital. So, like a bad thing to do is to have a huge expensive asset sitting idle. You want it to be used by people who really need it. And so bringing in the very severely ill Rhode Island folks would be like a good use of the assets, and then keeping less severe people in Massachusetts in more appropriate community locations could be beneficial.
My sense is that the asset is not remaining idle at the moment. But certainly where there are contemplations of expanded capacity for some of these institutions and what that may mean in terms of impacts on the cost and access in Massachusetts, that is always something that we think about as well.
Do we have a total number of what we think the overall impact would be in Massachusetts in terms of cost? Is it the 300? I mean, I didn't see a lot of numbers in this. I'm just wondering, are we getting to that point? Is that part of the final piece, or?
So I think the numbers that were displayed here were intended to kind of give a sense of the upper end scope of what the impacts could be. I don't think that we're planning to go much further and trying to crystallize a specific number. Where we could model and say, even in an extreme scenario, if all of these patients move to women and infants and to have a spending impact around $120,000 is a data point that we take into consideration. So even under some of these more unlikely scenarios of patient shifts, the numbers are not significant.
So David,
Can I just have
yeah, go ahead.
Thanks. Sorry. Just on the, I know we're going a lot to the Rhode Island process where we're not all experts. I'm wondering a few things. One, just to notice the healthcare workforce representative here. They do have in their statutory regulations, they'll review the impact of these changes on the healthcare workers and their wages and benefits. It's pretty interesting and unique that they have that here. We should think about adding something like that here in Massachusetts. I'm also just wondering with the earlier presentation around them moving to a cap, as well as I believe the Public Health Commissioner came to the Price Variation Commission about their approach around price variation and having a cap, but that will impact at all potential price increases on residents of Rhode Island based upon them moving to a little bit more of Massachusetts model, but also having kind of had a pretty aggressive, I believe, I don't remember the total outline of their price caps or their price variation issue, but I remember they did come to present how they try to approach it. Just wondering, do we see that having an impact of reducing the overall cost impacts of the residents?
That's right. So Rhode Island has a price cap right now on their hospitals. I think it's 1% above their state urban growth index. And so that would certainly play a role here in addition to the new benchmark target that David discussed earlier.
It is, I think, focused just on hospital prices, but they have some levers and some statutory authority to help potentially mitigate increases in prices. But I think beyond our scope to speculate whether those are sufficient in this particular circumstance.
Yes, Bobby?
Thank you, Megan. My question is a naive one, being a new member to the board, but when you say that people may move to other services, what are you basing that? Is that a mathematical projection, or are you looking at population density, transportation variables? Are there other variables that you consider?
It's a good question. So as David mentioned, we're looking at sort of the maximum number of patients that could shift. We're not speculating about how many of those patients will move. I think there are a couple of factors in leading to potential shifts. One is structural. The parties will have different incentives after the transaction to shift care to, partners will have incentives to shift care to Care New England that they don't now, and Care New England would have incentives to shift care to partners that they don't have now. And the other is simply the partners' increased presence in the region, their brand, potential marketing or advertising that they might do, increased ambulatory sites. It's possible even patients who have primary care physicians, not one of the parties, could be incentivized to move past their nearest hospital to go to women and infants for delivery, for example.
Thank you, that's all.
And I would say this is kind of the initial review process. Where we move into the longer cost and market impact reviews, and we do a more sophisticated analysis at that point around that would look at drive times, access to services, and we can model more precisely or can model more sophisticatedly exactly how many patients we think are going to move And we did that type of modeling with the Beth Israel and Leahy transaction, where we did look and try to model how many of those patients, new patients that they're going to have, are going to move from partners to Beth Israel or from other institutions. Here, given kind of the shorter time period, we did more of a, if 1% moves, this is what the price impact would be. But I don't think went so far as to say, here's the model that we think that X amount of patients will move.
So, one of the, as I was saying before, one of the reasons for going into this depth is to essentially develop a kind of a roadmap for how we might look at these kinds of changes that affect on the margin activities in neighboring states. Now, the one area that you didn't talk about, Megan, which I do think we ought to just touch on for a minute, which you didn't talk about, but I do think is something that we ought to potentially think about, is the financial implications of these moves on Massachusetts healthcare system. And just, well, not completely off the top of my head, since I used to live in Rhode Island, but we talked about this yesterday. The two potential impacts is, while neither Megan nor David talked about this, there is, as far as I understand, there is no financial commitment that partners made in taking this over. There's no dollar flow. In other words, they're not paying for these, for the integration of Care New England into the partner system, right? Correct on that, right? Second, they made no, in the information we have, partners made no commitment that they will invest X dollars in Care New England. However, when you look at the three bullets that Megan put down, one of the bullets explicitly says one of the reasons for doing this is to stabilize the financial position of Care New England. Now, they can do this in several ways. One is, in fact, by, as Megan pointed out, by establishing the brand. They could have more patients flow into Care New England from Rhode Island. That, being in of itself, really is an honor issue. It might be Rhode Island's issue. The second one, however, is a flow of dollars from partners into Rhode Island. And we just ought to acknowledge this. Now, as it turns out, you got big partners and little Care New England. So the impact of this happening is not really going to, under any conceivable, but it's something that I would think in our thinking we ought not to ignore, have any impact on the financial viability of partners going forward. However, there's a second, and that is the impact of this on other hospitals in the area. So as Megan has pointed out, there are two hospitals that are in the service area that Care New England affects, right? What is it?
Charlton
and Sturdy. And there you are dealing with potential impact. You know, Megan mentioned it, but they are in each other's service area, A, and B, it's possible that with the help of partners, they may choose to build more ambulatory capacity. Now, here's the tricky part. It's not at all, so first of all, I think we need to be clear about this. But then the question is, even if we're clear about it, what do you do? our job is, in and of itself, is not to pick winners and losers. And if they were to do this and develop a more competitive environment, say for Care New England and or partners in this area, and it negatively affects these hospitals, even to the point of one of them going out of business, what impact does that have on, well, clearly has an impact on the institution in and of itself, but what impact does it have on the patients in Massachusetts? And here's where life gets complicated. So my own view is, I think of all of the things that this affects, it's that one more than anything else, based on the information that we've heard. And yet, it's very long term, and it's very unclear. And from my own point of view, and I welcome other points of view, I don't think in and of itself it should be something that we would necessarily think is something that we wanted to stop. We wouldn't want to stop it if it created monopoly, but if it was just the competitive environment. Anyway, I bring it up not because I have an answer, and not because I think it's that important in this particular, but it's an important part of in this issue. Megan, David, makes sense?
Yes, I think as I said before, you know, in terms of where we may want to continue to track what the impact is, it really is in that you know, small geographic area in Massachusetts, but with some hospitals that, as we said, are significantly lower priced than women and infants, and so it's for maternity care and also for general kids care.
It's more than just the pricing. It's also access/quality. If the implication was that somehow it could wind up positively impacting on, if in fact you move to a quote unquote higher quality institution. But so I wouldn't just, in our thinking, I wouldn't just limit it to price effect. But.
Sure. And I would also add, and I think you mentioned this, Chairman, is that they also have plans to expand ambulatory services in Rhode Island, and where those sites are going to be located, what types of services are going to be provided. That may have an impact as well on some of those Massachusetts institutions that are nestled right near the border. They have not finalized those plans, so it's impossible for us to predict an impact at this point. But something I think we should continue to monitor, especially for the institutions really right across the border. All right, great. Well, thank you. That was a good conversation, and thank you for the feedback on that. As I said, we're in the final stages of our initial review and hope to make a final determination soon about what some potential steps next steps might be in terms of our review. So moving on to the next agenda item for the next about 45 minutes or so, and to get us out of here close to 2 o'clock, is shifting to the cost trends report. And so the cost trends report is our signature report of the year. And before we get into the presentation and to the discussion, I just really want to acknowledge the incredible work of the Research and Cost Trends team here at the Health Policy Commission, all of whom are around and behind me here, and the amount of work that goes into preparing this report cannot be overstated. Especially joined here at the table by the director of the research team, David Auerbach, and the deputy director, Sarah Sadamic. This is a report that we put out annually, but I will say the amount of work that goes into it stretches beyond 12 months. And so really want to give an acknowledgement to the team here. It is also, I would say, one of our reports that is truly all hands on deck report in terms of the entire staff. Every staff member, I think, read the report at one point to try to find missing commas and bullet periods, misspelled words. If you find them, don't tell us. And for commissioners, you do have a copy of the draft report. It is the last tab in your binders if you want to look at it. I also do want to acknowledge Ashley Johnston, who is our staff member who designs the report and the graphics included. We're very excited for the public to see this report. Hopefully it will be posted on our website later today. And it is just a beautiful report in terms of the design and the graphics. And of course, that is an important part of being able to tell a story, is being able to have something that is just incredibly visually engaging. And she does an incredible job for us. I would say I'm particularly proud of this report, and I was reflecting on this last night. I think this is, I think we often say at the Health Policy Commission, this is the best one yet, which I think is fair because we've only been here for 6 years, so I think it is a fair goal to say every year this should be the best one yet. This particular report, I really think demonstrates the sophistication of our data analytics. We have been able to, over the years, really grow internally our ability to mine the all-payer claims database and really have some new insights that, candidly, no other state has the ability to do. And Professor Cutler mentioned this earlier in conversations with other states. Their level of jealousy is palpable when they are able to see the things that this Commonwealth is able to do with our incredible data assets. And it has taken us time to build these muscles and these processes. And I think this report really demonstrates a deep understanding of some really kind of complicated trends in the healthcare system in Massachusetts, and is something that we're very excited to release to the public. So for today's portion of the presentation, we spent about an hour and a half at the last board meeting going through all of the findings of the report. So that is not the focus of today's presentation. Really, today's presentation, we want to spend some time discussing the policy recommendations that we're proposing to include in the report. And so all of these recommendations are informed by both the findings of the report, but also our cost trends hearings, our investment programs, our work across the agency. And so while, yes, they are included as policy recommendations of the cost trends report, they are in some cases broader than just the report in terms of setting out an agenda that this commission thinks will help advance our shared goals of cost containment and care delivery improvement. So to orient you, we do, here on this slide, you can see we kind of divide up the policy recommendations into two of our big policy priority areas. One around strengthening market functioning and transparency, and the second around care delivery and payment reform transformation in terms of our delivery system. So my plan here is to kind of take those in pieces and first just walk through our recommendations under the first policy priority, pause for some discussion, and then the second policy priority. And here, in addition to feedback on the recommendations themselves, I would encourage commissioners to help us think about what is it going to take to advance this recommendation in 2019. And so I want to hear from, hope to hear from you about, having said this recommendation, what is it going to take for us to help make this recommendation a reality moving forward? Finally, I would say many of these recommendations are repeat recommendations from past cost trend reports. Where we have new recommendations, we've indicated those with a little bit of an orange sticker. We have repeat recommendations in many areas where we have made recommendations and there still has not been sufficient action to address those policy areas, or in areas where we think that this is not something that can be solved in kind of 1 year, but that requires ongoing attention, focus, and work by all market participants. The last thing I would say is that in all of these recommendations, we kind of use the term the Commonwealth shall take action. And really by the Commonwealth, we mean a pretty broad constituency of both government, but also private market actors, insurance companies, hospitals, health systems, patients, advocates. In many of these cases, it's not just around changing a law, although in some cases it is, but really around a collective action to how can we improve the healthcare system. So with that, I'll just dive right into to these recommendations. So the first new recommendation that we included in this year's report is around administrative complexity. And I would say the recommendations that are included on these slides in front of you are highly summarized versions of a longer version that's in the report. So commissioners, if you want to look at the longer version, you can flip to the report in the back of your binders. For the public, just know that the full report goes into more depth and detail on each of these points, and we summarize them here for the purpose of brevity in these slides. The first one, as I mentioned, is around administrative complexity, and this was a reflection of a lot of conversations at the cost trends hearings this past year, led by a presentation by Dr. Amitabh Chandra, who talked about the fact that one of the contributing factors to the very high cost of healthcare in the United States compared to other developed countries is some of the administrative costs that go into our private healthcare system, delivery system, and payment system. We also heard from a lot of providers and health plans who are expressing increasing frustration around the number and varied amount of processes that it takes to deliver and bill for care, as well as use of electronic health records. And we heard a presentation from the Attorney General's office about the fact that many of our health plan and provider contracts have very different ways of paying providers for the exact same types of services. So all of this leads to a very complex healthcare payment and delivery system. We think that this is a top priority for the HPC to continue to investigate and spend some time in on 2019. And so this recommendation really is around identifying where are those areas of complexity that do not provide value or provide minimal value in terms of to the healthcare system, going through a process of prioritizing what areas we want to work on, and ultimately making some policy recommendations. So this is not a recommendation about necessarily this is the one piece of administrative waste that we want to tackle, but really a recommendation about a focus and a process for the next year to tackle this important part and this opportunity, frankly, to increase the efficiency of the healthcare delivery system. We'll pause here. I know this was a big topic of conversation at the cost trends hearing, so.
Yeah, I think this one is terrific, and I'm wondering whether we should tentatively plan to have another discussion of it at this year's cost trends hearings, where we can summarize potential steps that the Commonwealth, as the way you put it well, that the Commonwealth could take, and maybe even try and flesh out a time path by which we as a Commonwealth could do that. Because I do think since then we've heard from a number of providers and payers that they're very eager to be involved in this discussion and to make this happen. So I'm hopeful that we can put things out there, get discussion. Maybe what we'll put out probably won't be right the first time, that's okay. But we'll just help to coalesce where we should be.
Sounds great.
Just so I make it clear, and I hope you would follow this as well. There are a lot of actors, important players in our healthcare system. Patients, consumers that buy health insurance, employers that pay for healthcare, government that both pays for and also administers, providers at both the hospital and so on, payers and so on. So you got all these, and each player looks at this situation somewhat from their own vantage point. And what may be complexity and an unnecessary complexity and a waste. I was told we're not supposed to use the word waste, but that's what's often said, so I think it's an appropriate term. From one perspective, maybe a valuable, needed for another. And having been doing this for a long time and sort of been on every side of this issue. I hear discussions, depending on who you talk to, very differently. So as we, and I'm so conflicted, I'm completely objective. I don't even know who I am, what I should be. So all I'm saying is that as we look at this, we need to be careful about finding out why did this get set up? Who were the main advocates for it? Why did they do it? And then make another, this is why this is so complicated. And I took objection last time to the fact that if it's complex and affects providers, you take something like networks, very complex. A lot of patients don't like it, a lot of different so on, but it's a needed thing to make markets work. So it depends on who you are, all I'm saying. So then we then have to take that second and then you can have other things which it could be, if you looked at $3.4 trillion that we spend on healthcare, when you add it up, or the amount we spend here, it's not even a rounding error, but it's still not a trivial amount of money. So then you get both the costs and the benefits. So, and then ultimately you have to look at value. In other words, something may be not that costly, but add no value, or no, so therefore you might get rid of it. Others might be very expensive, but add a lot of value, so we have to acknowledge it. So as it couldn't be a more complex endeavor. And I wish us all well in this process of doing it. But I am going to be pretty concerned that we recognize that we need to look at it in very different ways, because I know each of us, depending on how we look at this crazy animal called the American healthcare system, could come away with very different views on what's the needed complexity and what's not.
Well said. And I think part of our process that we're planning is to really engage with the whole spectrum of stakeholders, providers and health plans, employers and patients, workers, the frontline workers and clinicians who sometimes feel some of the direct burdens of additional processes.
Took the words right out of my mouth.
And be able to catalog all of that and then be able to, I think, come back and say, where are those real opportunities and do some prioritization after that and think about where there may be very valuable procedures and processes that health plans require of their providers, but that each health plan does it in a very different way. The process might be valuable, but the fact that 12 health plans do it 12 different ways may ultimately actually impede the value of whatever that process may be. So certainly we are very early in this process, and I think an indication to all of the market participants in the room and others that this will be a big project for the year. Commissioner Foley, did you want to add to that?
No, you took the words right out of my mouth. I mean, looking at the perspective of workers on this, the training that goes into it, the complexity of having, again, different insurers, different codes, and the impact that has, how much time does it take them out of their day away from patients, what does it mean in terms of employment practices. I think this, as you said, there's many perspectives to look at this through, and I think one we have to keep in mind is clearly the frontline caregivers, and doctors are important in this conversation, but also everyone else that gets impacted on the floor of the hospital. I think that's a really critical piece of this conversation.
Great, thank you. So the next recommendation on this slide is around pharmaceutical spending, which has been an area of focus for the Commission for the last couple of years. Pharmaceutical spending, of course, is one of the key drivers of total healthcare spending in Massachusetts that we've documented along with hospital outpatients over the last couple of years. And while there's some repeats here in terms of some of the text, we do have a couple of new concepts and ideas that we recommend consideration of moving forward. The first is really around establishing a little bit more parity in terms of our oversight of and accountability of pharmaceutical manufacturers with how we evaluate already healthcare providers and health plans in terms of their contribution to total spending. We have laws and processes in place to judge providers and health plans. Pharmaceutical manufacturers are not included as part of those processes. So a recommendation here around is there an ability for us to further evaluate what high-cost drugs are, specifically in the Mass Health program, and think about an opportunity to provide for this state to have more data and information that could lead to increased supplemental rebates or help the Commonwealth negotiate better outcome-based contracts. And so this is a process, while not in the specifics, that New York has adopted and has had some success in terms of a more rigorous review of drugs and has enabled that state to negotiate higher supplemental rebates. So we do think that that is a promising innovation. Going a little bit further down this list in terms of some new areas, one data analysis that we conducted this year was around the potential for consumers to actually be able to get a better price for their drug at the pharmacy if they pay cash as opposed to paying on their insurance card or with their copay, and that there was actually laws or contracts in place that pharmacy benefit managers and pharmacies were prohibited from letting patients know that they could actually pay a lower price if they used cash. The federal government has now passed a law prohibiting those types of contract provisions that were intended to shield patients from information. What we're proposing here for consideration is that there are actually states who have gone even further and said that pharmacies should have that information to be able to proactively provide and to help patients know that if they can pay less on a cash basis than through the insurance copay, that they have that information and can guide patients appropriately. So even more consumer disclosure. And that also goes to the next one down, which is around more transparency of pharmacy benefit managers and the prices that they're charging for drugs. And then finally, where we did an analysis of oncology drugs that are under the medical benefit, and that there is significant variation in the prices for those drugs that are being bought by providers and administered to patients, that those should not be excluded as we think about drug impacts, that there is an increasing amount of drugs that are actually flowing through the medical benefit, and that those should be considered for reforms as well. Other provisions here in terms of value-based contracting and risk-based contracting, more treatment protocols and evidence are ones that we've made in the past. Any questions on kind of the pharmaceutical side of this?
So I think this is a hugely important issue. I'm a little bit where Stuart was earlier, which is I think there's one of Dante's 7 layers of hell, which is devoted to understanding pharmaceutical. And I think it's not just next to the one where you consider administrative costs. I'm not sure which one is more inner in it. I think a couple of things here. One is I think it would be nice if we had like a small white paper summarizing the options for the legislature and or for plans and Medicaid about this, because there are a number of different strategies buried here. And some of them are things that are easier to do, some of them would be things that are harder to do. Some of them require legislation, some of them don't. So I think it would be nice to lay it out in a way that says, you know what, here's kind of what the menu looks like, and here's things that would make sense as a package if you want to do it this way. If you can include more legislation, you should think about potentially doing it like this. I'm worried that I'm a little worried that if it's just a series of laundry lists like this, that it won't quite get the traction that it needs. And so that's one issue. And then the second issue is, I think we may have to do do something to get access to rebate data. Because in order to do the kind of review that we would want to do, which I think we absolutely should do, you sort of need to do it on the X rebate data rather than on the list price data, right? Like it would be like, trying to evaluate, whether the Commonwealth is meeting the target by using list prices, not transacted prices, which would just be a poor substitute. So we may need to do something about getting access to the X rebate data as we do this.
So a couple of reactions and agree, and thank you, Commissioner. One, I would note that the recommendation in the report is more detailed than what's presented on the slide. And in addition, in the report, we do actually have a call-out box that details kind of a summary of what other states are doing in this space, and has kind of a compendium of other state strategies. States are increasingly active in this space, and many states have passed laws or proposing laws. I would, of course, note that the legislature here in Massachusetts did include provisions in the healthcare bill that was being under consideration last year that would increase transparency and the ability to get some of that rebate information, both for CHIA and for the Health Policy Commission. And I expect and anticipate that the legislature will continue to look at potential pharmaceutical reforms as they consider legislation this year. And of course, want to acknowledge the governor and Secretary of Health, and Secretary Sutters, of course, in their proposal with the budget, that also tried to, I think, put forward a thoughtful proposal around some of these issues. So this is obviously a very ripe issue in terms of the administration and the legislature priority that I have heard the governor, the secretary, and many members of the legislature put forward. So I do think we want to be supportive of that process as it moves forward in doing what we do best, which is bringing objective research and data to bear to help inform these. And as Colleen mentioned, we're going to have a number of individual reports coming out over the next couple of months on coupons, on pharmacy benefit managers, on distribution channels, which will all, I think, again, provide a lot more information. So take your point, though, around how do we put that all together into the most usable form for policymakers. Any other thoughts or reactions on pharma? Great. Seeing none. The next slide here I will not spend much time on. These are all repeat recommendations from prior reports in areas where we still believe that action is recommended. First is around protection of patients for out-of-network billing situations, including providing advance notice to patients, holding patients harmless and prohibiting bills for patients who, through no fault of their own, either in an emergency situation or through a provider on the care team that is out-of-network or receiving out-of-network bills, these outrageous bills should not be passed on to consumers. And to back that up, a process whereby providers can be fairly reimbursed for the services that they provide, but to remove, as many other states have done, the consumer or the patient from the process of out-of-network billing and to create a protection against these surprise bills. Provider price variation continues to be an issue that we recommend action on. This is, I don't know that I need to say much more on this issue other than it continues to be one of an underlying factor that in our healthcare system and has not been addressed by policy actions to date. We also continue to recommend efforts to prohibit the application of facility fees.
I want to stop you.
Sure.
Excuse me.
Yep.
On the provider price variation. Just to acknowledge something and then to ask that more work needs to be done. The term unwarranted is a tricky term. You and I were on the Price Variation Commission And we, during that commission, you had the Mass Hospital Association come up with their definition of unwarranted, what was warranted, what was unwarranted. You had the discussion that came in the report. As far as I know, we've never really tackled that issue explicitly. And the question is whether we should or shouldn't. Because in that term, if you talk to the various parties, you know, depending on where they are in the spectrum and what they do, they would say, yeah, there's price variation, but all of it's warranted, and this is what we do, and this is why we do it. I'm not taking sides here, but I've been uncomfortable with the term warranted and unwarranted for a long time. And again, it's often in the eye of the beholder. So at some point, we may want to get into this to help the legislatures deal with this issue. So as I was reading it, it reminded me again that it's an area that we really, and maybe I'm wrong, maybe we did take it up, but I don't remember taking it up here. I do remember the discussion there.
Yeah. So just as a reminder for the rest of the commission, this issue of warranted and unwarranted factors for variation in the prices paid to providers was something that was explicitly part of the Provider Price Commission's charge, and was something that commission spent a fair amount of time working through. I think the final report did have some recommendations about what would be considered a warranted factor versus an unwarranted factor. I would also note that at least one of the legislative proposals in terms of healthcare reform last year also picked up on that same topic and had a process. I think the Health Policy Commission and the Division of Insurance, if I'm remembering correctly, had some role in kind of determining what those factors were in terms of a review process. But absent, absent a legislative directive, we have not, I think, advanced that topic internally, and understand that the legislature may want to weigh in terms of what a process may be for that. But I think open for discussion about what, if anything, more that the Health Policy Commission would want to provide in terms of research and information on this topic. We have done a number of reports. So.
Yeah, but just for example, I've been asking, and I know you have too. Maryland, for example, has a very complicated formula. You know, it's an all-payer system, but it's not the same. And depending on whether you're an academic medical center, whether you're a rural referral center, or whether you're a community hospital, you get different rates, and they have an actual significant, complicated formula. And I've often asked for that formula and never gotten it. Remember, you or not. So, you know, just collecting, you've laid out the history as I remember it well too, but hidden in that term is probably the biggest motive, because under some circumstances there is no price variation, and depending on how you look at it, and in some there's a big one. So I just want us to remember and not get lost in that as you slide through it.
Sure. Professor Michael, did you? So sliding through it, on facility fees, again, we have highlighted hospital outpatient as one of a key driver of spending in the Commonwealth. Again, here too, both other states and the federal government have taken steps to both prohibit the licensing of new hospital outpatient departments unless in certain circumstances, and that restricts their ability to charge a facility fee. There have also been, beyond that, efforts to say for certain types of services that can very safely and effectively be treated in a physician office and a hospital outpatient department, that there should be a standard payment rate for those types of services, like a standard doctor's office visit, and that here too, consumers are rightfully confused about why they may receive a bill that is twice as large for a standard doctor's office visit that looks and feels like a standard doctor's office, but is licensed, not to their knowledge, as a hospital outpatient department where they're able to charge additional fees. So again, an area for reform. And then finally, on kind of demand side incentives, or thinking about how employers and health plan purchasing can play a role here too. Some repeat recommendations, but did want to highlight again a strong encouragement around utilization of the connector as a very high value place to be able to purchase health plans for small employers who are otherwise being burdened with high and rising premium costs.
On that one, this may be for our fellow commissioner. Did we observe a big increase with the shock labor in the use of the connector by small businesses?
So as of with 1 year underneath the relaunch, we're seeing double the lives. I think last memorandum was about 3,000, and we're up to about 6,000 lives now. So we're actively kind of looking at other ways to attract and get the word out there to employers that this is a high value place to shop, and I think some of the savings that employers have experienced by shopping through the connector on average, it's about 20%. That it's really driven by behavior and types of plan that those employees are selecting.
So moving on to the second kind of policy priority areas, these are more focused on the delivery and payment system. Many of these, starting on slide 45, are again kind of repeats. First, a general recommendation around continued action to reduce unnecessary utilization, and there's a number of different sub-metrics that we look at and track. We have made some notable progress in some of these areas. In other areas, such as hospital readmissions, we have not made progress and actually have gone in the opposite direction. I would note here that there is some controversy around the metric around hospital readmissions, and that may be a continued area for the Health Policy Commission along with other state agencies to think about, is that the right metric that we should be tracking, where there is some emerging evidence that it does not adequately take into account the different social factors that patients have and that the patients that hospitals treat that may drive readmissions rates, and some concern actually around patient safety, around a focus on the way that readmissions have been measured to date. So just want to highlight that as an area of probably continued research and focus around what is the best metric for thinking about post-hospital care. On social determinants of health, this is, again, a repeat recommendation that we've been making in terms of a continued focus on this part of being able to improve care for patients. The one kind of new sub-recommendation here is just something that we've observed through our investment in grant programs, that where there can be collaborations between community providers, community organizations, the healthcare system, perhaps the judicial system, the education system, the municipal health authorities, to really think about addressing upstream social determinants of health, that there is a lot of promise and opportunity, and so the Commonwealth should think about helping to support those types of collaborations that really kind of go, as I said, to think about some of these institutional inequities and historic inequities that end up driving healthcare costs, and how can not just the healthcare system, but healthcare system in partnership with a lot of other community providers and organizations work together to address those. On the next page, again, these are two repeat ones, but ones we think are still nonetheless very important. The first is around advancements in the healthcare workforce. Some sub-recommendations here around reviewing scope of practice restrictions, and we have made recommendations in the past around removing restrictions on advanced practice nurses. We've also made recommendations in the past around establishing a new level of professional for oral health care, continued support for this team-based care model, and I think a broad statement of support about how, through all of the work of the Commonwealth, we engage the healthcare workforce in that policy development and program activities, and explicitly think about that in the development of work, not something that's kind of tacked on afterwards at the end.
Were these recommendations in the bill that the legislature was considering last year, or do we need to push these stronger?
So the bills, without speaking to one bill or the other in terms of the House and Senate, there were reforms absolutely on the table in terms of scope of practice, and the governors and the administration did propose some important reforms around scope of practice, not just for advanced practice nurses, but for some other specific healthcare professionals. At least one of the bills did include this establishment of the new dental practitioner. There was, I think, support in both bills around supports for the care-based model and community health workers and using peer recovery coaches. So these were, I think, reflected in at least one or two of, one side of the bill or the other side of the bill, and I think will continue to be areas of priority for the legislature and the administration moving forward. And so I wanted to continue to emphasize our support for some of these reforms. I don't know, Lauren, if you want to add something.
I was actually going to mention a recent collaborative that just kicked off related, it's being headed by the Executive Office of Labor and Workforce Development in collaboration with some private partners, and I think the focus is really on healthcare workforce issues throughout the continuum, so direct care, personal care, all the way through registered nurses, and so as that work kind of picks up and moves along, it's also part of that effort. We'd be happy to kind of report back and think about areas where there's synergy and ways that we can dovetail on the work of that group.
That sounds great, and I think we would want to be thoughtful in terms of what the HPC's agenda here is, that it is complementary and supportive of a lot of other efforts in the healthcare workforce space. And I think an area for us to have, I think, a further conversation at an upcoming meeting around, of some of these topics, which ones the HPC may want to lean into and provide some research and data to in the coming year. And I'm looking at both Barbara and Tim. I look forward to your input and feedback about where we can help advance a positive conversation that is, of course, complementary with other activities.
When the bills are filed, could we come back and make comments on them? Could we say, we like this, but we encourage you to add more? Because this in particular is one area where we really felt very strongly as a commission. And so if they've gone halfway there, we point out, actually, there are other ways you could go.
I think we would need to see and understand exactly what the legislature is proposing and what would be appropriate for us to weigh in on the legislative process. I think in some ways these recommendations provide a statement of support.
Yeah.
So I think it's a little early to speculate. On the second half of this slide is again, kind of some areas where we think that we should continue to invest and test new ways of delivering care. We highlight here a couple of different new emerging models, but particularly want to call out telehealth, telemedicine as an area that we think should continue to be expanded and supported in the Commonwealth. And I do want to just, again, acknowledge a very recent and important policy update that Mass Health made just, I think, 2 weeks ago in terms of expanding coverage for behavioral health care services through a telehealth modality. And so this is, I think, a really important payment update for Mass Health, and we would love to see other commercial payers follow their lead in terms of being able to provide payment coverage for these types of services, which we believe have the real promise to expand access, especially in cases of mental health and substance use disorder, where access is such a challenge.
David, you left out at the same rate as an in-person visit.
Yes. What is the payment rate is an important policy question, of course, Mr. Cohen, and Mass Health did say that they would pay at the same rate as an in-person visit for those visits and services.
I think two other areas to think about, which are really cutting edge issues, are both robotics and artificial intelligence. Both those areas, especially robotics, are looking at and monitoring frail elders or frail individuals in homes, is a growing field, probably led by the folks in Japan, who have done so much more of that work than we have. So on the radar screen.
Yeah, absolutely. That's a great point. And the emerging AI and data ability is also a kind of an emerging technology field that we're trying to keep track of. So, and then the final recommendation is, I think, one of our perennial ones as well, in terms of the continued adoption of alternative payment methodologies and value-based payment methods. We saw in this year's report that the uptake of APMs has stalled in the commercial market, although there have been significant increases of new payment adoption through the Medicaid ACO program. In the commercial market, we've stagnated in terms of the amount of revenue that is through an APM, and what we consistently have heard, both from providers but also the academic literature supports that in order for providers to truly change their behavior in terms of having the incentives to reduce unnecessary utilization, they need to have a certain threshold of payment that is coming through these types of alternative payment methodologies, and that providers are still living in between two worlds in terms of a fee-for-service model and a value-based payment model. So we want to continue to see adoption of APMs to get us over that threshold and really be able to change the incentives. The one slight nuance here is, I think, a recommendation that these payment models should include downside risk for the providers, and this is a reflection of really emerging academic evidence that for these models to really change the incentives of providers, that upside-only arrangements have not been as successful. And so as we think about it, it's not just taking on new payment methodologies, it's what is the design of those payment methodologies that makes a big difference. So that is a broad set of 11 recommendations touching all parts of the healthcare system. I think we highlighted and front-loaded the conversation in terms of some of our priority areas for the coming year in terms of administrative complexity and certainly in pharmaceutical spending. But we'll kind of open it up to commissioners in terms of any other feedback or input as we think about this report, but also a lot of work to come as we advance these recommendations.
Well, that was quite a great list. So any further comments or questions? Yes, we do. All right, so we need to vote to
Issue.
So is there a motion to second? Okay. Okay. All those in favor? Opposed? Abstention? Very good. Again, I couldn't agree more. This is a fantastic report. Thank you all, particularly the analytical team. Also, I have to give a special shout out to the graphs are great.
63 unique graphs, charts, and tables in the report and chart pack. So thank you, commissioners, and thank you for all of your input into this report. You gave us great edits and feedback that helped shape this report. And for the audience, we will
One last thing, David.
Sure.
Just to show you that I'm not totally asleep. We did ask you for an update, more of a comprehensive summary of what was in the Beth Israel Leahy stuff. Where are we on that?
Sure. So we have been in touch with both the Secretary's office and the Attorney General's office. I think we think it's appropriate probably to have that conversation after the transaction has officially closed, which actually isn't until March 1st. So we are preparing and planning to have a conversation about all of the conditions around the Beth Israel Leahy, what types of reporting we might see, and we'll have that at the next regularly scheduled board meeting. There may be, depending on the time limit, we'll know what the appointed monitor of that transaction may be at that time. So I think we felt there was going to be a more fulsome update at the next board meeting.
Alright, so, we have, the next meeting, David?
The next meeting will be at the State House at Gardner Auditorium for our hearing on the modification of the healthcare cost growth benchmark on March 13th. And the rest of the schedule here is on the slide. I would just note we did reschedule the December meeting, so if you put the calendar in your phone, please update that December meeting.
Yeah, and I do, I think it's worth, David was nice enough to summarize the fact that we now have 3 states that have gotten into the benchmark business with slightly different rates, but, the benchmark was a unique aspect of 224, so we have, and I know there are several groups around the United States that are pushing many more states to join in to our little club. So, any further comments or questions? If not, I would welcome a motion to adjourn. All right, second. All right, we are adjourned. Thank you all.
Yeah.